Rupert, again, thanks for putting this together. It's always a pleasure. And Sarah, thanks so much for putting this together. Yes, and it is kind of the unification theory here, the theory of everything. Yeah, I'm glad to have a chance to talk about this. A little bit different talk, just an idea of sort of breaking out from what we normally talk about a little bit and trying to put some things in perspective. I do have several disclosures. I'm always glad to share them if anybody's interested. But let's get started for sake of time. So going way back, Amit was talking about the early ketamine studies. We'll go back here to Socrates. So it's this treatment of a headache. And if you read this, it says, the thing was a certain leaf, but if there was a charm to go with the remedy, and if it was uttered, and if one uttered the charm at the exact moment of the application of the leaf, the remedy made one perfectly well. But without the charm, there was no efficacy of the leaf. So this is going back, pre-biomedical times. But it was this idea that you had this combination of a thing and a charm together, the treatment along with the whole setting, that really led to the response. And that was really how, for the longest period of civilization, we treated medical treatments. This was it, up until the very recent biomedical revolution, really. So if you think about our evolution of what a treatment actually is, it starts with this original thing that there's a thing charm that gives you the response. And it really wasn't until the early 20th century that we started to really pay attention to the fact that, all right, well, there's the treatment, but then there's these other things, like the natural history of the disorder, a regression to the mean, or even the Hawthorne effect started to become appreciated. So people said, well, all right, there's the treatment, and that has its effect, as long as you could subtract out these other things. And then that lasted into the mid-20th century, when people really started to say, well, wait a minute, people that are given a drug, even if it's inactive, are still getting better, and at a higher rate than just solely due to the natural history of the disorder, or regression to the mean, or due to the Hawthorne effect. So they started to reappreciate the charm a little bit, that there was something to the treatment itself that had an effect. And then recently, we started to have this idea that, well, it can actually be an interaction between the thing and the charm. So for example, if you give a medication that has some type of an effect, that could interact with your belief or your understanding it's going to work. So for example, with ketamine, if you have some type of immediate response that's functionally unblinding, and if you have this expectation that if I have this immediate effect, I'm going to get better, so now you have an amplification of the charm. And then only more recently, what I'd like to say is it gets even a little bit more complicated, where there may actually be a two-way interaction between the charm and the thing. So now we're starting to think that there may actually not only be this functional unblinding and this way that can influence the way you think about the charm, but as we heard from a few people already, these drugs may actually be changing how you perceive things or what your expectations are like independently of the drug, actually changing the the neurosystems that are regulating that. So let me just go through the history a little bit, just because they're really cool stories. And trying to put this all in perspective is, where's the importance? Is it activation of a specific region within the brain, or is that accounting for a small sliver of the effect, and the big effect is coming from what people expect? And I think we really have to think about that, especially as we move forward in clinical practice, but more so even in clinical trials. All right, so let me just start with what I thought was one of the most amazing stories I've read in a long time. So how many people know the story of Mesmer and mesmerism? So some people have heard this, just incredible story. So late 1700s, Anton Mesmer, a Viennese physician, but before that was studying in college, really thought he came upon some work that found a new force of nature. This was 100 years or so after Newton. Ben Franklin recently really wrote his treatise on electricity. So people were starting to understand these unseen forces in nature. And there were a few papers coming out about animal magnetism, this force that unified the universe. So coming back to truly unifying the universe. And Mesmer really jumped on this, and he believed that he was able to control this unseen force of animal magnetism. And he believed that many illnesses were directly related to having the animal magnetism either blocked or not flowing properly through the body. And he started to develop these techniques of using magnetic water, these baquets that he's developed, these baths, and treating patients of all different maladies with this magnetic treatment, and actually having pretty good responses. And it started to grow in popularity. And it started to grow in popularity, especially among the aristocrats in Paris, where people more and more started to go. And he was having these phenomenal outcomes as per their reports. More and more, he worked his way into the court of King Louis XVI. Marie Antoinette was going. He really started to gain a lot of attention. And that, at one point, became his downfall. And again, this is a little bit of a lesson for us, especially as we start thinking about where things are going here. As more and more people started to get involved in this, especially the aristocrats, they started to fund his clinics a lot. They started to give more and more endowments to his clinics and less to the Royal Society and to the established medical communities at the time. They didn't like that. And they went to King Louis XVI and said, you have to debunk this guy. You have to say that this is not real. And it was with that that Louis XVI formed two commissions to investigate Mesmer and specifically the use of animal magnetism. And he actually hired Ben Franklin because of his recent work in electricity, and Lavoisier, the famous chemist. And he asked them to really investigate what's going on. But he gave them a very specific marching orders, which was, is there such thing as animal magnetism? Go prove to me that there is or there isn't animal magnetism. So Franklin and Lavoisier set up these incredible studies, really like the beginning of clinical trials. They had concealed this treatment where they had people being treated behind a black sheet, so they didn't know if they were being treated or not. They had people that were being treated, but it wasn't with magnetic wands. They had all different types of things set up. And they went through many months of this, going through it. And at the end, they came up with a pretty firm conclusion. The commission unanimously concluded there was no evidence to prove the existence of animal magnetic fluid. And then they say imagination without magnetism produces convulsions. Those are these crises that they could actually develop with the wand where people would actually have seizures or pseudo-seizures and then go on. But they said that you can produce these without any magnetism but just imagination. But magnetism without imagination produced nothing. And then they went on to actually claim that anybody who speaks French, I apologize, une invention illusoire, vaine et funeste, or basically, this is an illusionary, vain, and disastrous intervention or invention. It's really interesting because Mesmer himself didn't agree to be the participant in these studies. It was actually one of his junior colleagues, Dessalines, who agreed to do the study and be the one applying the treatment. And at the end, when they came out and said, this is just people's imagination, Dessalines said, you know what, I don't totally disagree. Maybe what you call imagination, I call animal magnetism. And he said, but I see my patients really getting better. Can you investigate this? Well, this seems to be really important. Can you guys investigate that? And it was very clear that they say, no, our job was that. But there was a separate report issued just for King Louis XVI himself that actually wrote that they were very concerned that this was a danger to the medical establishment and society as a whole, as it constituted a regression to superstition in less enlightened time. So it's amazing how much of a sort of an international political statement. There are all these letters from Ben Franklin, going back with Thomas Jefferson and a lot of the sort of the leaders of the American Revolution at the time, with Thomas Jefferson really urging Franklin to publish this data and squash this as quickly as possible because it really threatened the Enlightenment. So it really reached a level where these are all the world leaders really coming down to squash this because they were really worried that it was going to challenge the Enlightenment. Because we all know that leeches and emetics are the real science, and that's the way to go. And that's what the established medical community had at the time. It really wasn't until the beginning of the 20th century when Harold Deal at Minnesota was looking at a vaccine for colds. And he had a finding where he was looking at people, and he was using this new vaccine for the regular rhinovirus, and he found 55% reduction in the number of colds with people that were giving that. Unfortunately, he found 61% reduction in people that were just given a saline shot. And that was really one of the first times when people started to realize, like, oh, wow, you can actually, it's amazing. It was not that long ago when people first started to realize, like, wow, you can get pretty big effects with nothing, with saline. Deal didn't actually make much of it. He just said it's kind of interesting. He said, but what this proves is that the vaccine doesn't work. He didn't make too much about the fact that there was a big reduction in the number of colds, at least a perceived reduction. Really, the next step was Harry Gold. So I don't know if anybody knows, but really one of the big forces in medicine, especially in looking at placebo-controlled trials. A cardiologist, and what Harry actually did was look at xanthines. So at the time, xanthines were the treatment for anybody who had coronary artery disease with angina. So if you had angina pectoris, you were on a xanthine. And there was really good preclinical evidence. Preclinical evidence was great that this is a vasodilator. You put it on, you get vasodilation. You do it in animals, you can show vasodilation, increased blood flow. Everybody was convinced these work until there were a few reports saying, that it's really variable how well they work in different parts of the world. So it was a study that went on in the UK, and Harry Gold set it up here, until they found out that there was absolutely no effect of the xanthines in terms of a difference in pain. Any effect they could see with the xanthines, they could show with a placebo. That was 1930s. The reason I put cardiac surgery, because it's a little bit more exciting than saying xanthines, but the other part is the major surgery, heart surgery at the time, was the internal mammary ligation. And it was based on work showing that if you ligate the internal mammaries, it causes collaterals to develop and you get increased blood flow back into the coronary arteries. And that's really gained popularity throughout the 1930s, 1940s. It became really one of the major cardiac surgeries at the time, less invasive than doing any other cardiac surgeries, and people thought it was effective. And they were reporting up to 70, 80% response rates until that was actually put to a sham control test. And they actually had no difference. In fact, numerically, people that just had the incisions but no ligation actually did a little better. So it's just this idea. It really, the charm wasn't reappreciated until late 1930s when Henry Beecher, so people may have heard this name, anesthesiologist up actually in the Boston area, the Harvard schools, really wrote this paper called the Powerful Placebo in the late 1930s. He didn't get the terms correct as he could, and he gets a lot of criticism for it now. He called it a placebo effect. And what he was saying, about 35% across all of medicine, about 35% of the response rates he sees could be attributed to placebo or sham. He called it a placebo effect. He should have called it the placebo response, because we'll talk a little bit more specifically what a placebo effect is. But it really wasn't until then, that wasn't that long ago, before people ever even appreciated that there is such a thing as placebo response, or more specifically a placebo effect. And just quickly to put it in perspective, there really was no talk of doing placebo-controlled trials. And the US FDA in 1962, the year before I was born, was the first time they ever said, you probably should do a placebo-controlled trial. Pretty amazing. And even the story how that came about is another whole completely interesting story. It wasn't what they were setting up the commission for. They actually were setting up the commission because there was concern that the drug companies were developing these new drugs, mainly antibiotics and stuff, that weren't really that much better than the existing ones, but charging more money. And Kiefer and Harris set up this commission. They wanted the companies to prove that their drug was better than the existing drug to get a FDA approval. And they actually asked one of the top physicians at the time, a guy, Louis Lasagna, to comment on it. And he got up in front of the commission and basically said, "Well, that's crazy. That's almost impossible." He said, "We can barely show the drugs are better than placebo." And that's, the senator's like, "What? What do you mean?" And, really interesting stories how we got where we are. But now you talk a little bit about how important are these non-specific effects in psychiatry specifically and what we're dealing with. And, in my mind, this is one of the real interesting, and a paper that I think everybody should read. You take from it what you want. I've heard a few brief comments on it already yesterday. It's a paper by Mark Stone looking at all the FDA trials. I think it was from like 1979 to 2016 or 17, and just looking at the difference between the actual response rates, which I'm afraid to try this pointer, but actual response rates, which is here, which is about 9.8 Hamilton points, versus the placebo, which was about 8. So if you look at it, about 82% of the overall effect could be attributed to these contextual effects, not specifically related to the drug. It's a pretty big effect. And that's over many, many studies. So we have to think about that as we're moving forward. How much of any response that we're looking at is specifically related to the drug, and how much of that is related to one action of the drug, whether it's an opiate, whether it's an MDA, whether it's at the amygdala, or whether it's at the entorhinal cortex. I mean, you start to get really small components of the overall response. I always make the point of emphasizing this is not unique to MDD. I mean, this is osteoarthritis, huge effects. Probably many of you know the surgeries. If you're looking for osteoarthritis, especially some of the lavage surgeries, could never show superiority to just putting 2 holes in the knee. So this is across all of medicine. And interestingly, mental health is, I don't know if you can read this, it's really small. It's kind of in the middle when you look at mental health, where these proportion attributed to contextual effects are. Cardiovascular system actually has some of the highest. So looking at antihypertensives and some of these other treatments, really high proportion attributed. So you can see we're not mental health is not the outlier at all. And even if you start to look at, because we said we're just using subjective tests, we're just asking people how they feel. Even semi-objective tests and other measures, end expiratory volume and breathing for some of these asthma medicines and stuff, they're worse actually. So they don't perform any better than the subjective ones. So it really goes across fields, and it's just something to think about as you're moving forward. And even what type of outcome? Everybody said, well, survival has to be, right? Survival actually has one of the highest levels of proportion attributed to contextual factors, because there's so many other things that contribute to whether or not somebody actually lives. It doesn't mean that the placebo effect is big, but it means the placebo response is impacted by so many other things. So then you have this this efficacy paradox. And this is something I think came up a few times today, when in fact, we're so focused on the delta in these studies. What's the difference between the active drug and the placebo? That sometimes it doesn't mimic what the actual effect is in the field. And in fact, if you get a really large effect size, a really large clinical effect with a treatment, sometimes it may be difficult to actually separate it from, especially if there's because there's a relationship between the clinical effect and the placebo response all the time. So it gets harder and harder. As your placebo response grows, it gets harder to show that your treatment works. So you could have a treatment that works in 100% of people, but if it worked in 90% in the placebo, you probably couldn't show that it worked, which is pretty ironic, and this is this efficacy paradox. And I think Wayne showed some of the data already, and I don't want to belabor this at all. This is with ketamine, and I think you see a little bit of this. You see this was the this was the fixed dose study that actually didn't reach statistical significance with ketamine, right? I think at 0.08. But if you actually look, compared to the STAR-D, you're seeing twice the rates of response of remission, even with the placebo, but even higher than that. And you look at response rates of over 53%. In their in their flexible dose study, you're seeing response rates of almost 70%, 50% in the placebo, but you're seeing, again, almost 52% remission rates. So when people say, well, it didn't work by that much, that's because it had a 30% remission rate in the placebo control, which is still twice what you would have expected in the STAR-D. So this is over 3 times. So to say it doesn't work is kind of not, you're really stretching what work means. And the same thing with, if you look at the ASPIRE studies in the patients with suicidal ideation, you're seeing remission rates of over 54%. In 150, it averages about 50%. That's pretty good. These were patients that were hospitalized with a suicide, because of suicidal ideation. To say that didn't work is a real stretch. Again, almost 40% just with the standard of care treatment, which was not standard of care, which was a much higher level than we would typically give in that study. All right, so lastly, what constitutes this proportion attributed to contextual factors? So part of it we talked about is these regular non-specific effects, the natural progression of the disease. People get better. Regression to the mean, most of the time people go into a clinical trial or go to see their doctor when they're feeling they're worse. You just give them some time, they're usually going to get better. Or the Hawthorne effect that most of you know, just simply being under observation, people do better. There's even evidence that just giving the MADRS over and over can actually get people better. So that there's just being observed, people tend to do better. But, it's difficult to really do studies to understand this, but one way of looking at it is to look at wait list and to try to get at it that way. And Brad Rutherford and others at Columbia have tried to do some work, and they estimate about 1/3 of this is really just due to those factors. But that means the rest of the effect is actually due to placebo effects, things like expectation, conditioning, and therapeutic alliance. And so now if you start to look at this, you start to see that when you're looking at the specific drug effect or the specific pharmacology, it's a really small slice of that overall response that you're looking at. And again, I just put this in here again, just to remind me, it's not unique to depression. It's not unique to psychiatry. It's across medicine. This is another study looking across all fields in medicine. And one of the ways of getting at expectations is to do concealed treatment. And I don't know if people have seen this, but this is Benedetti and Luana Cloca has done these studies where you have an IV placed in somebody and you either tell them you're going to give them the drug, and they did it across all different buprenorphine, tramadol, ketorolac, or the metamizole. If you tell them you're going to get it, you get a much bigger response than if you don't tell them you're going to give it. The opposite of that is you can actually, same thing was done with Valium. Sorry. These slides are getting mixed up in some way. The same thing is done with Valium. You could do the same thing. If you tell somebody we're going to push Valium, they feel much better. If you just push it and you don't tell them, they feel a little bit better. Even with deep brain stimulation for Parkinson's, telling them you're going to turn it on and then turning it on, they get a big change in their motor symptoms. Just turning it on, but don't tell them, they get some, but not nearly as big. I don't know why these slides are now mixed up there, but I'll just say the other thing that Teresa, I don't know if Teresa's still here, but Teresa presented her data. There she is, Teresa. But it's being covered up here for some reason. I don't know why, by part of the slide. But if somebody said, if we're going to take people that are depressed, really aren't doing well, and while they're under anesthesia, we're going to give them some ketamine. And let's see how they do the day after. And if they told you that 50% of that group had a remission, you'd say, wow, that worked pretty good, right? Unless, when you did it, now the slides are really not, unless 35% of the people that didn't get it also had the same remission rate. So the slides are mixed up. I may have to stop there. They're kind of jumbled a little bit. But looking at it, this is looking at from Teresa's study, it didn't really seem to make that much of a difference. This is now looking at the 14-day level, whether they actually got ECT, whether they got the ketamine or got placebo. But if they thought they got the ketamine, and this was done later, they did much better than if they didn't know or they didn't think they got the ketamine. Let me see. And again, these are really, the slides are jumbled for some reason. So the other is the ketamine study that Amit talked about, the ketamine versus ECT, where he showed you the data, which is here, showing that we can say that there was no meaningful difference, or ketamine was not inferior to ECT. That's the way the study was designed. But if you actually look at it, ketamine did better in most measures. But going back, if you look at it, this is looking at what they preferred. We asked late, it was only about 2/3 of the study we got to ask. We asked them what they preferred. They didn't give a choice, they were randomized. But if they got ketamine and they preferred ketamine, about 60% of them responded. But if they got ketamine, but they said they preferred ECT, only about 20% of them responded. Interestingly, ECT didn't look that way. And the other interesting thing is that if you're asking people about the side effects, it looked like it was more, if they got ECT and they said they wanted ketamine, they had a higher percentage had side effects than if they said they wanted ECT and got ECT. So it's just that it's pretty contextual. It's not so straightforward. The other part is conditioning, and I'm just going to flip through this. We all know conditioning. Even with ketamine, it's been shown if you can give ketamine to rodents in the same space for a few times, then the next time you just have to take them in, and they'll still get an antidepressant-like response. And again, it may even be sex-dependent on that even. So the last thing is the therapeutic alliance. I just want to go through this very quickly because there's just a few minutes left. And for this, I'm actually going to go back to 1961. And I don't know how many people here have read this book, but it's been one of my favorite books to find after all these years. I don't know. Alan, did you know Jerome? This really interesting book going back. And what he tried to do is try to understand what's the core elements of psychotherapy. And he really distilled it down to 4 main things that he would say. 1, emotionally charged, confiding relationship, a healing setting, a rational conceptual scheme or a myth that provides plausible explanation for what's wrong with the patient and how what you're going to treat them with is going to help. And then the last is some type of ritual or procedure that's involved in the care that has to involve both the patient and the treated. So if you think about what we're doing with ketamine or with psychedelics, we like, if we were to take a lesson from Jerome Frank, it's exact emotionally charged, confiding relationship. That's very much what we're doing with ketamine and ECT or psychedelics. A healing setting, I think it all has to do with what you consider a healing setting for many. Again, the slides are mixed up. Whether you think these are healing settings or I'm really sorry, or if you think this is a healing setting, something along those lines. At the time Jerome Frank wrote the book, it was a couch and a chair was the healing setting. The rational story is very much, this is work that was done my lab and my colleagues' labs, this story about neuroplasticity, which really makes beautiful cartoons, spine density changes. I show it to all my patients. Look, we're going to change your spine density. Neuroplasticity, this is it. You want that convincing story. Or for other people, the slides are mixed up. Or for other people, it's the story of you're going to have some metaphysical experience, and that's going to change your life. And they both are these convincing stories. And I think you really have to contextualize it to the person. And then lastly is this ritual belief. And I can tell you all of these treatments are highly ritualistic. Whether you're coming in to get ketamine or esketamine or Spravato, you're going to get your blood pressure. You're going to get everything done in a way that is very ritualized. Or if it's going to be a psychedelic treatment, you're going to get very ritualized, possibly even having the medication handed to you in a chalice. So these are all, depending on what you consider the ritual, they're all very ritualized. So just to wrap up, this is really, it's the complexity of the treatment, how many different things contribute to it. And if you start to pick apart, if you think your one drug is going to hit one receptor and that's going to be the difference, you're trying to thread a needle, a really small area, because there's so many of these effects that have that impact. I'm just going to leave it like that because the slides, I don't know what happened, really got confused at the end. But the idea now that we have drugs that I truly believe drugs like ketamine and psychedelics and probably ECT and all of these do have major impacts in neuroadaptation. We call it neuroplasticity, whatever we want to call it. It is actually changing brain function pretty dramatically. So we may actually have a chance, and I think we heard earlier today about changing expectancy, not just expectancy having an effect, but the drug's actually changing your expectancy or your prediction of future events. So we're at a unique time. If we learn how to take advantage of it, I think we have real possibilities. My fear is we're throwing drugs out by saying, oh, and to address Alan and a few other that the NMDA receptors haven't shown effect. If you look at these studies, they're having 18, 19-point drops in MADRS. But so is the placebo. So much better than, I don't think any of the studies with olanzapine added to an antidepressant had a 19-point drop, or aripiprazole. So you're having bigger effects than these active treatments. It's just that the placebo is doing it. So I think we could be too quick to throw a drug out just because the placebo response is too big. All right, I'll stop with that. Thanks. That's part of the trip.
A lot of food for thought there.
Oh, okay.
Any questions? How can we square it with the imperative of consent?
So the people that do a lot of the placebo research, that's always what they talk about. And there's even arguments now that open placebo, Fabrizio Benedetti and others will talk about it. In Parkinson's, they do some studies actually saying, this may be a placebo, and we're going to give it to you. And they argue that you get almost the same effect. But I think the literature is pretty sparse on that.
I meant in clinical practice.
So I would say, a lot of us we hedge on that all the time, right? How do we do it? You want to give informed consent, but so much work has been done on the flip side of that is the nocebo. How much do you actually tell your patient about side effects? Because you can clearly induce side effects through the nocebo effect. And these are things, I don't have the answers, but I think it's really time for us to talk about because these effects are so much bigger than the drug-specific effect. I'm a molecular biologist, pharmacologist, all the way. But if you just look at the data, there's no doubt those effects are much bigger than the drug-specific effect.
Go ahead.
Jerry, yes, really interesting talk. I have a question. So many of these studies of placebo or these contextual effects are look at the short-term effects. What about the longer-term effects, and are they as persistent? And I'm thinking of like older studies where for people with recurrent depression, if you were to discontinue the antidepressant, they were more likely to relapse. So is it something that you see easily seen in the acute short-term, but what about long-term?
So that, Adriana, that was always the lore in the field. That's what I was brought up with. Placebo is short-lived, and the real drug response isn't. The more recent data doesn't bear that out at all. That these placebo responses continue to grow. In fact, any big companies here run a recent trial, it's been killing them because that placebo response rate just keeps going down and down and down. And the longer the study is, the further it goes down. So I think we have to not be afraid to challenge ourselves to really say, is the lore correct? Is this real, like placebo short-lived? The data doesn't seem to show that. In most of the studies that actually look at response curves, it's pretty identical between the active and the placebo.
Thank you.
Gerard?
I wonder if you could comment on one recent strategy that the FDA has suggested for looking at psychedelics, in addition to having actual, placebo, to actually do dose response work. What do we really know about expectancy and placebo when you're talking about doing dose response work? And I'm also stretching out to dose response work for things that really have clear, obvious functional unblinding, and things that actually have absolutely no functional unblinding. Do we really know anything about those situations?
So that's a great question, Gerard. I think, and that is part of the FDA is very much looking at that, and they're struggling with this whole idea now of making sure that there's a guess at it too. And this really goes full circle, goes back to the Mesmer thing in my mind, where are we just trying to debunk, going back that we're so afraid that these other effects are so large that we want to debunk them. And I think we have to really think, what are we doing? Do we want to show that this is a drug-specific effect, or do we want to develop treatments that are going to help patients? And how do you balance those two? As I was reading the Mesmer thing, I was shocked. I mean, this became an international geopolitical thing where they just wanted to crush him because they were so afraid that it was going to challenge the major scientific establishment at the time, and the medical establishment, which was not good. I mean, they were putting leeches on people. I think we have to ask those questions. They're hard questions. How much are we going to push it? I think it becomes, what's the relative safety? Because if you're giving drugs that have real risk, then you really got to challenge that more.
I cut my teeth on glaucoma trials, and I'm quite certain that even Mesmer couldn't have reduced somebody's eye pressure. Cannabis maybe, Mesmer no.
Yeah.
But in all of those trials, you see substantial reductions in eye pressure over time in the placebo group. We don't call it a placebo effect. We call it regression to the mean.
Exactly. It's part of the placebo response, not the placebo effect.
Placebo implies we did something. In all of these clinical trials, we're taking somebody at an acute phase.
You waited.
We're selecting people who are at an acute phase of their disease.
Exactly.
They're going to get better over time because that's the natural history of their disease. It's not a placebo response.
It is a placebo response. It's not a placebo effect.
Okay.
Yeah, because the definition of placebo response is you get it while you're on a placebo.
Yeah.
So no, I agree. That was the whole point I'm trying to say. But if you add all these things up, it leaves very little room for that drug-specific effect.
I think we ought to move on.
We have to move.
Thanks.
Thank you.